This patient is presenting with intense pruritus, self-induced alopecia, and a secondary bacterial pyoderma localized to the caudal dorsum, complete with active hemorrhagic crusts. Pet owners frequently interpret this extensive tissue damage as the mechanical result of a parasite bite. In reality, the bite is a delivery mechanism. The flea mouthpart piercing the epidermis injects a microscopic trigger that initiates a cascading systemic immunological crisis. Flea Allergy Dermatitis, or FAD, operates as a multi-pathway hypersensitivity disorder. It is a biological event that moves far beyond the scope of a standard infestation. The adult fleas visible on the host represent less than 5% of the total parasite population. The remaining 95% exists as an environmental biomass maturing off the host in the surrounding home. To achieve clinical resolution, we have to look at the intersection of two distinct biological nodes: the host's specific immune pathways and the parasite's developmental receptors. This requires moving past a basic pest control approach and analyzing the case as an integrated biological system. The pathology begins at the molecular level, the moment the parasite breaches the dermal layer. During feeding, flea saliva enters the host, carrying a cocktail of histamine-like compounds, enzymes, and specific polypeptides. This cross-section illustrates the salivary injection. The primary triggers are specific polypeptide antigens weighing less than 60 kilodaltons. These cross-link with IgE antibodies on mast cells, triggering a type 1 immediate hypersensitivity reaction. 24 to 48 hours later, a type 4 delayed cellular reaction compounds the inflammation. There is a specific relationship between the frequency of these bites and the severity of the host's reaction. Intermittent, sporadic exposure to these salivary antigens is exactly what drives the severe, tissue-damaging hypersensitivity reactions just detailed. In contrast, dogs exposed continually to flea bites often develop a natural immunological tolerance, characterized by lower levels of circulating IgE and IgG antibodies. Clinical severity is determined not by the absolute number of fleas, but by how intermittently the host is exposed to the antigen. While the microscopic trigger is identical, the macroscopic presentation of that inflammation diverges sharply between dogs and cats. In canine patients, the presentation follows a highly predictable and localized anatomical distribution. Looking at this canine wireframe, the topographical heat map shows the classic clinical pattern: inflammation concentrated on the mid to caudal dorsum, the tailhead, and the caudal thighs. Chronic barbering in these zones leads to annular papulocrustose lesions and eventually firm fibroperitic nodules. The feline model shows a far more variable pattern. The hypersensitivity reaction is often diffuse, affecting the head, neck, dorsum, and inguinal regions. Feline FAD typically breaks into 4 distinct reaction patterns: head and neck pruritus, self-induced alopecia, miliary dermatitis, and the eosinophilic granuloma complex. Because cats are fastidious groomers, they often physically remove the primary evidence of an infestation, including the fleas themselves and the flea excrement. Diagnosis in cats must therefore rely on recognizing these specific hypersensitivity patterns, as live parasites are often absent during the clinical exam. The primary challenge in a clinical setting is the patient presenting with severe, undifferentiated itching. Clinicians must systematically rule out food allergies and environmental atopy before committing to a definitive FAD protocol. Identifying food allergies requires looking for concurrent gastrointestinal symptoms, though these are not always present. This flowchart illustrates the diagnostic requirement. A strict 8 to 12-week novel protein or hydrolyzed elimination diet is the only way to definitively rule out food-triggered pruritus. Environmental allergies, or atopic dermatitis, are isolated by mapping seasonal variants and utilizing serum IgE or intradermal testing. While intradermal skin testing is effective for environmental triggers, it is no longer recommended for FAD diagnosis due to low sensitivity. Instead, FAD is confirmed through the visual identification of flea excrement, reddish-black pellets that dissolve in water, or through a successful strict ectoparasiticide trial. Once food and environmental triggers are removed from the equation, we can apply the specific pharmacological mechanisms needed to break the cycle. Effective treatment requires a dual-node blockade, neutralizing the host's immune cascade while simultaneously disrupting the parasite's life cycle. The host management node focuses on breaking the itch cycle immediately to prevent further self-trauma and infection. In this host node, oclacitinib acts as a selective JAK1 inhibitor. It physically blocks the cellular receptor, halting the inflammatory signal before it can trigger the itch response. The parasite management node targets the adult fleas currently on the host. Ectoparasiticides like isoxalanines act as neurotoxins. They specifically antagonize GABA and glutamate receptors in the flea's nervous system, leading to rapid paralysis and death. But treating the host and the adult fleas only addresses 5% of the problem. Biomass management is the final essential step. Pre-emerged adult fleas remain dormant in cocoons for up to 30 weeks, ready to reinfest the host. To combat this, insect growth regulators like lufeneron are essential. They disrupt chitin production, physically severing the life cycle and preventing larvae from reaching the pupal stage. A JAK1 inhibitor only masks symptoms, and isoxalazine ignores the environmental biomass. Success requires all three nodes. We return to the patient at the start of our journey, the severely itchy, alopecic dog. We can now trace the invisible path from that less than 60 kilodalton salivary antigen to the systemic dermatological crisis we see on the skin. Resolution is achieved by moving beyond standard pest control methods and utilizing targeted biochemical pharmacology. This dual-node approach modulates the host's hypersensitivity, restoring homeostasis, while systematically eliminating the environmental biomass. Under this protocol, FAD becomes a predictable, manageable disease. Clinical success in veterinary dermatology occurs when the host, the parasite, and the environment are treated as a single, interconnected biological system.